Hello, I'm Carol Reed. I'm a member of the Needham Coalition for Suicide Prevention. And we're happy today to welcome Dr. Kevin Hill from McLean Hospital to talk to us today about substance abuse and related mental health issues that are indicated in suicide and suicidal ideation. Dr. Hill, thank you for coming.
Thanks for having me.
And could you take a minute to share with us a little bit about the work you do at McLean?
Sure. So I'm one of the addiction psychiatrists at McLean, so I do clinical work there and also research. So clinically, we have a variety of programs where people come in and receive treatment for a variety of substance abuse issues. I would say probably 40% alcohol related, 40% opiate related, and 20% everything else. So in addition to that clinical work, I also do research related to developing treatments for some of these substance use disorders. In particular, I have a grant that is looking at developing treatments for marijuana dependence. So we're running some clinical trials now developing treatments for marijuana dependence. And as it stands right now, there are no FDA-approved medications for cannabis, and we're trying to develop some right now.
Extensive work, and we are fortunate to have you here because as our coalition works to educate the community, we understand this significant correlation between substance abuse and the risk of suicide. And our goal today is to have you share some of the information that a community can take in to enhance their protective factors. And I know that the research that we've read recently indicates that 60 to 90% of people who have attempted or taken their life by suicide have a mental health or substance abuse disorder. Can you share any background and elaborate on that for us?
Sure. So that means there are a lot of factors that play into somebody actually completing a suicide. And so to me, those statistics underscore the hope that is available, the reasons why people like you and I should try to educate the people of Needham as to what types of things they should be looking for in people that are suffering from mental illness or issues like depression or substance use. And so if you're able to perhaps identify people that are having these kind of problems, you can intervene, and there are treatments available that actually work. And so if you can get in there before things get out of hand, perhaps we can prevent some of these acts from happening.
Mm-hmm. I know that substance abuse and depression and anxiety are treatable disorders with medication and behavioral therapy, most often a combination of both. Can you share with us what type of signs people should look for with friends and family that would motivate them to reach out for treatment, and perhaps also elaborate a little on the stigma that holds people back from addressing mental health and substance abuse issues?
So the stigma is very prominent, and we'll get to that. But I think in a situation like this, it's important to think about the most common things that people can look for. And so I think when you think about people that are contemplating suicide or actually attempt suicide, I think depression and substance abuse are two things that often play a role in these kind of situations. And so in terms of depression, there are certain signs and symptoms that we can look for. It's the depressed mood, obviously, is the first one and most prominent one. Somebody's just not acting themselves. They seem to be sad or blue on more days than not. A difference in sleep. Is somebody sleeping more? Are they sleeping less than usual? Interest in terms of, are they still doing the things that they like to do? Energy is another instance. Is somebody, they may not be sleeping well, but they're in the bedroom all the time. Again, they're not getting to school like they should be. They're not participating in the things that they normally do on a daily basis. I would say appetite is another thing. Somebody dropping weight is a sign that we often worry about. Concentration. So again, you may see that in terms of somebody not performing in school or at work as they might normally. Something that we call psychomotor retardation, which means that just somebody who is they just seem to be in slow motion all the time. They're just not themselves in many ways. And then suicidal ideation. I think it's important to talk about the fact that if you talk to somebody about how they're doing, a lot of times people will say that they have thought about doing something, or just thinking about maybe not wanting to be around as much. Somebody can actively think about suicide and think about having a plan or what they might do, but they also may be a little more passive and say, yeah, you know what, it may not be a bad thing if I didn't wake up tomorrow. And those are obviously red flags. And those are situations where if you can identify somebody that's having some constellation of these symptoms, they'd be somebody that you'd want to try to make a referral for, or try to coax into seeing a counselor, a psychiatrist, or a nurse, or whatever. I mean, just to try to get somebody into treatment is a very important thing. In terms of substance abuse, some of the similar stuff, usually just a change in behavior. So somebody who used to be very active in extracurricular activities, they don't want to do it anymore. They're not, participating in sports like they used to. Again, the change in somebody's performance at school or work is very critical. Somebody that might have a new set of friends that they don't want their parents to meet. So I think those kind of things are things that can be looked at as indicators, as perhaps somebody is starting to use marijuana or alcohol in a way that they maybe hadn't before, and something that we could be concerned about. But I think these kind of things underscore the importance of communication. And we're not talking about iPhone and texting back and forth. I'm talking about talking with somebody about how they're doing. I mean, I think a lot of times in the way that things are these days with communication and texting and that sort of thing, we do a lot of superficial communication, but it's important to sit with somebody and actually try to get a little bit more out of them as to how they're doing. And a lot of times people, what I find when they come in to see me or my colleagues, that they want to talk about it. And they might not want to initially, but if you probe a little bit, and then they get a sense that, hey, this person's interested in how I'm doing, then they'll begin to open up a little bit. And that's when you can start to talk about the things that are bothering them and make a change.
Right. And in Needham, I know you're very much aware of the gatekeeper training that many of us facilitate in the community called QPR, which is exactly what you are outlining, that we can make a difference. We don't have to be in the medical field or social workers. Everyone can be a gatekeeper and be aware of these signs and open up the conversation with people to identify the behaviors they see, such as underperformance or lack of energy, those type of things, and actually ask the question, what I see is not your usual self. Are you feeling like things are too hard? And the next step, have you ever felt like you wanted to hurt or take your life or end your life? I mean, it's difficult word tracks, but we all have to get used to the fact that being very clear with people, because I know with taking one's life by suicide, people almost see that as a relief of pain, not hurting themselves. So it's a way for them to stop the pain that they're feeling, and often self-medicated by substances. So to be with QPR, we give people those word tracks to say, be very open about using the words of taking your life, as opposed to just saying hurting yourself.
Sure. Programs like QPR are great, I think, because we have to keep in mind the fact that most people that have mental illness don't ever get any treatment. So, it takes a lot for somebody to come in to sit in an office with somebody like me. So that the people that are around them in their school or in their workplace or their family are the ones that more often get to see what's going on. And if those people can be aware of the signs and symptoms to look for, we're better off than we would be otherwise. So you mentioned the stigma before. That's another reason that keeps a lot of people from getting treatment. I don't want people at my workplace to know that I'm getting help for depression, or I don't want my friends to know that this is going on. And what I say about that is, we need to try to help educate people about the fact that these kind of mental illnesses are chronic medical illnesses, just like asthma, just like diabetes or high blood pressure. So they have genetic components. And there are a lot of factors that play into these things. These are issues that can be treated effectively, as you mentioned before, with either behavioral treatments or medication, or hopefully a combination of both. But if you step in and you treat these problems, you can manage them successfully. They don't ever go away. Somebody that has depression is going to have to deal with it for the rest of their lives, and it can be managed very effectively, but it's something they need to kind of keep on the radar. It's like somebody that has diabetes. I mean, they need to keep on top of their diet. If they're taking a medicine, you have to take the medicine every day. Similarly, substance abuse issues, if somebody has a problem with alcohol, they're always going to be at risk for having these kind of episodes. And so we want to intervene and help them figure out a way that they can manage these problems. So I agree that programs that help people reach out and identify people that might need treatment are great, and we need to try to promote these kind of programs whenever we can.
Mm-hmm. We know with suicide and substance abuse, there is no age boundary, no gender, no cultural boundary. Can you share with us a little bit about what you see with substance abuse and the correlation between, perhaps some certain age groups that are more at risk?
Sure. And I think it's important. You were talking about suicide before and suicidal acts and how they impact so many people, and they look at them as relief a lot of times. And it's been said that suicide is a permanent solution to a temporary problem a lot of times. And I think that gets back to the kind of impulsivity that you mentioned. Would this kind of dramatic act be something that somebody would do if they were in a clear-headed state, if they weren't depressed, if they weren't in the midst of drinking large quantities of alcohol? And a lot of times people would make different choices. I mean, frequently in the emergency rooms, we see people that come in and their families brought them in because they're talking about suicide, and they may be in the midst of drinking for several days or using other drugs. And a lot of times when they have a little bit of time to let those substances pass out of their body, they're like, wait, I'm not interested in that. And we still want them to get treatment in those cases, but they may not be at acute risk. And so you were saying about what we see in terms of substance abuse and the different demographics. And obviously, really mental illness, whether it be depression, anxiety, substance abuse, these problems don't discriminate. Suicide does not discriminate. And so anybody is at risk. And we see people of all shapes and sizes, so to speak, who have these kind of problems. They come in and in a way, you can strip them down and they look very similar. People have, had things happen that have kind of set them adrift, and they're feeling sad about it. They don't know what to do. They feel overwhelmed. And it could be somebody who's in high school, they didn't make the team that they wanted to make, or they got rejected from the college that they were hoping to get into, to somebody who is, managing a portfolio for a Fortune 500 company, and they didn't get the promotion they wanted. So these things look, the details are different, but in essence, they're very similar in many ways. And so we try to help them kind of pick up the pieces and get the treatment that they need. Obviously, it's disappointing that you didn't get into that school, and I'm not sure what we can do moving forward about that, but what I do know that if you continue to drink the way that you're drinking, it's not going to end well. And we see, a lot of times when things don't end very well. And again, I would just say that in terms of the suicide and the relief that people talk about, I mean, suicide is devastating. And I can tell you, from a personal standpoint, a professional standpoint, that these kind of actions that people take, they leave a tremendous amount of wreckage. And so people, when these things happen, healthcare providers or family members all wonder, was there something that we could have done? Maybe if I had done this, things would have been different. And I do think that there are, again, what we're here for, to talk about signs and symptoms of these problems that people can act on. And there are things that can be done, but sometimes, there's little that can be done. And so, I would just caution people who may not be feeling very well or having depression. I mean, think about these other people that you're going to be leaving. I mean, some people, when you talk to them about suicide, will say, well, I can't do it because I couldn't do that to, my mother or my siblings or that sort of thing. So there are protective factors, but sometimes people don't think about it that much. If you had something bad happen to you and you're out drinking, you're not going to think about the potential ramifications of these actions, when you're out and you're inebriated, let's say. So that's why the impulsive actions, or things that can change the way that you think about what's going on, are very dangerous. And we try to help people avoid these impulsive situations. So, and I know that part of your program is about that too, to try to educate people to avoid initiation of substances that may lead to impulsive acts. And so that's why that's important.
Mm-hmm. I know in working with youth in the community as well as, older adults, many challenges or stressors, people don't have the positive coping skills, to deal with them, so they turn to substances. So we're trying to work with people to say these things are effective for stress management, and make sure you're connecting with friends during challenging times, and understand the importance of trying to recognize the feelings you have in yourself, as opposed to just using alcohol or other drugs to deal with these challenges.
Yeah, a big part of what we do is we try to promote healthy coping strategies as well. And I think that drugs like marijuana, for example, are particularly dangerous because every time you smoke, you feel a little bit better in that moment. And people say, well, you know what, this is helpful to me. But in reality, you're kind of digging a hole. I mean, these have longer term impact upon the way that you may see things, or it could affect your mood. It could help you be more dysphoric than you might normally be. There are other obvious effects from smoking as well, but I think these are things that make it a bit more dangerous because people will come to me and say, well, it's the only thing that can calm me down. I know that every time I smoke, I feel better. And we talk about how, when you do that, sometimes you need to smoke more. And again, your judgment is clouded in these instances where you do. And so, these aren't benign drugs, and so bad things can happen. It's not to say that, I'm not to paint this with a broad brush and say every time somebody smokes something bad's going to happen, but you're opening the door to these situations that really can have can engender a bad outcome.
Mm-hmm. We work through our various resources that we have here with the information from NIDA or NIAAA, and interesting research with marijuana and the correlation to depression and suicide. Can you elaborate on that for us?
Yeah, the way I look at it is you think about sort of a chain of events. So the end of the chain is a suicide, a completed suicide. So what kind of factors may play into that kind of event occurring? And so we talked about earlier, really mental illness of very many different varieties, but most commonly depression is what we see. People are profoundly depressed. And so then you think about further down the chain, what are things that can worsen somebody's depression? If somebody is susceptible to being depressed, are there things out there that can make it worse? And certainly using marijuana is something that can exacerbate somebody's depression. Drinking is something that can make it worse too. And so it's a chain of events, and if you can intervene at any one of these links, you have a better chance of lowering the risk for somebody completing suicide. And again, that's why I say, not everybody that goes out and drinks on the weekend is going to have these problems. There are people that smoke occasionally. I mean, more people use marijuana than any other illicit drug. There are millions of people, and a small fraction of those people meet criteria for what we call marijuana dependence. But if you think about it, a small fraction of a large number is a pretty large number. So that's why when we're recruiting for our studies, we get pretty good responses, because there are a lot of people out there who, after smoking for a long time, begin to realize, you know what, I'm not cutting it at work like I really should be. What's going on? What am I doing? Maybe there's something I can change here. And that's often what happens. The instances where people come into treatment for marijuana usually aren't as dramatic as they might be for opiates or alcohol, but eventually the same sort of problems occur. You see problems at work, or your spouse may give you an ultimatum. Look, it's either me or you're smoking. You need to do something about it. And so ultimately, when they come in and they sit down across from me, they're in very similar circumstances. And not a lot of people realize that. People say they don't understand that marijuana, they say, is it really addictive? Well, it sure is. I mean, there are a lot of people out there that smoke on a daily basis. And when you do that, bad things can happen. And again, as I said, it's not everybody, but it's a proportion of those people that are having a problem in a very serious way. And those are the people that we're trying to help get treatment.
Mm-hmm. And I know with decriminalization, a lot of the youth I interact with, and as well as the adults too, they don't see that marijuana is harmful. And it's a challenge for us to try to share the science and the research that we have now through NIDA and different organizations that say, brain imaging shows that there's a distinct change under the influence. Can you elaborate on that?
So two things. In terms of the decriminalization, I mean, it's something that I get asked about a lot, and I try not to get into that piece. I mean, certainly alcohol is a legal drug, and a lot of people use alcohol responsibly, and there are a lot of people that have problems with alcohol. Marijuana is very similar. So whether or not it should be legalized, I mean, it's probably not, the topic for today. I will say this, though, that certainly since Massachusetts made it essentially a civil penalty for carrying an ounce of marijuana, which is a lot of marijuana, by the way. One of the slides that I like to show is, what an ounce of marijuana looks like. I mean, you can, roll up to 80 joints out of an ounce. So that's a lot of marijuana. So again, marijuana can have, negative consequences. In terms of the development, there's been a lot of work done at McLean by Harrison Pope and others, and Stacy Gruber is another person at McLean that's doing great work in this area too. And to boil it all down, certainly early initiation of what we call heavy marijuana use of people that might meet criteria for dependence definitely has long-term, it has cognitive impact upon the developing brain. And so what Dr. Pope's research has shown is that 17 is really kind of a key age. So the brain is developing, and if somebody is initiating smoking in a more serious way before 17, the risk goes way up. And so that's all the more reason for us to try to intervene where we can. And if you look at the data, I was looking at the data for Needham, which mirrors really the national data. You have a small fraction of kids in 9th grade and 10th grade, but really 10th, 11th grade is where people are really making having their first experience with marijuana. And again, if we can educate them, hopefully it'll be something that will just be something that they try and not start using in a serious way. Because if you use in a serious way, we're learning more and more about the long-term effects of that. And so we're trying to avoid people getting into those situations when we can. And just another piece in terms of the access, because you mentioned the laws, I don't think we need the laws to change very much because kids can get whatever they want. You should also keep in mind that the marijuana that kids smoke these days is far, far stronger than the marijuana that people used to smoke 10, 20 years ago. It's probably 3 to 5 times as potent. So, it's a whole different ballgame with what's available these days. The fact that there is decriminalization going on, or that there's medical marijuana available, makes it so that there are people that can grow very strong strains of marijuana without the threat of, they're doing it under legal auspices oftentimes because they're, developing it for these clinics. And so the end result is that the marijuana that people are getting legally or illegally is very strong stuff, and it's not something to be taken lightly.
Right. And I was reading Dr. Nora Volko's research. The same parts of the brain are activated with marijuana use as with cocaine and other drugs. Is that true in the brain? I don't mean true, but can you elaborate on that a little bit? I
mean, there's a variety of receptors that are on the brain, and essentially there's the reward pathway. So different drugs activate different receptors. Typically marijuana is activating the cannabinoid receptors, and so the drugs that we're using are activating the cannabinoid receptors, and obviously opiates like OxyContin and heroin utilize the opiate pathways more often. But really there's this reward, kind of this dopaminergic system, certain parts of the brain, like you said, that are involved in reward, that all these drugs use to some degree or another. The proportions of which receptors often differ, but really the pathways are very similar. And so that's why Dr. Volkoff at NIDA was concerned about the recent data that shows that while use of cigarettes, for example, is going down and use of alcohol is going down amongst teens, marijuana use is not going down. In fact, it's kind of stalled out, and that's actually true in this area too. And so that's something to be concerned about. We'd like it to be such that people are learning about the harmful effects of these drugs and therefore using them less. But for some reason, whether it's availability or there could be other reasons, use of marijuana is not declining, and that makes it something that we need to be concerned about.
Mm-hmm. Mm-hmm. Well, we are looking at continuing to share the scientific and the experiential information that you're sharing here today with us to motivate parents and adults of all ages to look at the science and to look at the research that says these are not healthy choices,
Mm-hmm.
Substance abuse, and they're linked to long-term mental health and potentially life-threatening behaviors is real. And we're not in any way trying to cast a moral judgment or, just simply trying to share the science and the data to help people make healthy choices, and also to say these are preventable, treatable disorders. So to motivate people to reach out, look at the resources that they have in our community and in the surrounding communities, and get good consultation. So we are, if you had 2 or 3 things to share with families, or to how to intervene with a substance abuse issue that they could help their loved one, what could that be?
Yeah, I'd say the first one is something we talked about a little earlier. It's communicating. You have to be vigilant about trying to communicate. I know it's difficult, with kids of all ages, really. A lot of times they don't want to tell you about what's going on, but you have to try to stay on top of it and communicate in a meaningful way. We're not talking about texting. So you need to know sort of where they are, what they're doing, how they're feeling, and try to help them understand that despite the fact that you may want them to do things a little differently, and they certainly pick up on that, as long as they understand that by your interest, that you really care about what's going on, eventually they can come around and feel comfortable in talking with you and when something's not going right. So you're asking them about how they're doing, you're looking for signs that something might not be going right. And if you are able to have them tell you something's not right, or if you pick up on that, there is treatment available, and treatment that works. And it's not easy, obviously. When you get into treatment for these kind of issues, a lot of times we'll have families pull a kid in to treatment. And so then we do what's called readiness work a lot of times, where we just, in a non-judgmental way, lay out the pros and cons of use. One of the important things that I like to talk about when I'm working with somebody, are what are the things that they think they get out of using? Their positives to it, right? I mean, people who go out and drink, it feels good in the short term, obviously. It creates certain risks, but there are reasons why they engage in these behaviors. And so I want to talk about that. And when we talk about giving those kind of behaviors up, I think you have to talk about what it's like not to be able to do something that you enjoyed to do. So we're talking about grief in many ways. So I think when you lay these sort of things out with people, whether it be kids or adults, eventually they realize, I do like to drink every weekend, and I probably drink too much on the weekend, and I probably could be doing better at work. Eventually they kind of come around, and if you sit with them for a few sessions, a lot of times they'll eventually become open to your recommendations about what kind of treatment they want. Even when they come into treatment, though, again, we're talking about relapsing, remitting conditions. So people can be doing well for a while, and they may be depressed, and they come into treatment, and they're getting therapy and maybe a medication, and they feel like they're doing really well, and it's like, yeah, you know what, I don't want to schlep over to the therapist every week again, and eventually they stop going about it in the rigorous way that they may have initially, and then things begin to fall off. And so people can have ups and downs in their treatment. And
Yes.
Similarly with substance abuse, that happens a lot too. And so what we try to help people do and families do is just hang in there, grab on
Right.
and hang in there. And again, just kind of stick with it. And eventually, if you're able to show them that you care about what's going on, and then that maybe they see something that isn't going the way that they want it to, and they might need a change, the light goes on at some point. We hope that they don't lose that much. And again, a lot of people, there's a lot to lose, and a lot of people lose great opportunities, whether it be relationships or academic opportunities. But we try to get in there and intervene before people lose those sort of things. But it's a bumpy ride, and I think that's what people that work in this field are kind of adept at doing. You have to battle. People are going to do well at times, and they're not going to do well, and they're going to relapse, and they're going to call you in the middle of the night, and that's what we expect. And you have to have a desire to do that. It's difficult work, but people can do very well.
Yes.
And I think that's very rewarding. And so I would say that if your child or somebody in your family isn't doing very well, there's a strong reason. There's reason to be hopeful about it if you can just identify the problem and try to coax them into getting some treatment. Get help. Don't worry alone. That's something that I've been taught throughout my training. Don't worry alone. There are a lot of people out there that want to help you. And so, that's why a situation like this is so worthwhile, because we help to show people that, there are people out there that want to help you.
Yes.
Pick up the phone and then, let us kind of do what we do.
Right. There is a lot of hope, and you know, I like the fact that you said you don't have to do this alone. And we have a number of resources we're going to show on the screen here for people to reach out. McLean, obviously, among the very wonderful resources we have here to access. So I thank you for being here. You are very kind to spend time here in Needham and share your expertise, and we're grateful that you can reinforce the fact that, like any chronic illness, it's a long road, but it's absolutely real that help and change is a part of this. So thank you, Dr. Hill.
Yeah, great. Thanks for having me.
My pleasure. Thank you.